one thing that's become more and more of a problem is that it's really hard to go a shift now in our busy urban emergency department without treating someone for a heroin overdose or someone who's in opioid withdrawal. I actually ask a lot of my patients, like after they've been reversed with the life-saving drug Narcan, how did this start? And I can clearly remember multiple cases where they've told me that this started after a prescription for an opioid for seemingly good reason, and then they started getting it from friends and family, and it just started from there. So it's become critical to reduce the amount of excessive pills that are in the community that could be abused, particularly ones that are prescribed for acute pain. So one of my first jobs as an attending in the ER, the resident physicians came to me with prescriptions for prescription opioids, and they kept on giving me prescriptions for 30 tablets. And I asked them, why 30 tablets? And I realized that in our electronic medical record at this other institution, the default number of tablets was 30. And I realized how powerful the default could be in writing these prescription quantities. So after I transitioned here to Penn and we had the opportunity to change our electronic medical record, our emergency department team actually included a default prescription amount for 10 tablets. And what we noticed is that when we switched from our old medical record, which did not have a default, to our new medical record with a default of 10 tablets, that prescribing changed overnight in our two emergency departments. So now what we're doing within the health system with more pilot funding is taking this approach across a whole host of procedures in the Department of Orthopedics, neurosurgery, and even general surgery, with the goal of right-sizing prescribing by procedure using these data and implementing procedure-specific defaults that are informed by what patients actually need.